Okay, well, good evening, everybody. This is the monthly third Thursday Symposium of the University of Miami in cerebrovascular and skull-based surgery. It's a delight to be doing this for so long now. This is session 37, and we have a fantastic panel for you today. I will introduce the speakers at the end of this introduction. I remind you, those of you who've been faithful and coming to our sessions regularly, we are down at the bottom left there, and you can see what's coming ahead in the coming few months. Along with the speakers will be my current fellow, David Altschuler, who will present a case after the four speakers have given their lecture. Well, I'm Jacques Morcos, professor and co-chair of the department here, director of cerebrovascular and skull base. Always my pleasure to have my co-directors in this course, Carolina Benjamin, who you got to know over the last several months, who's specialized in brain tumor and skull-based surgery here at University of Miami and Jackson North Hospital. Michael Ivan, associate professor, director of research at the Brain Tumor Initiative, and Michael specialized in brain tumor, skull base, and epilepsy surgery. And last but not least, Bobby Stark, co-director of endovascular and director of our endovascular research. I encourage you, those of you interested in pediatric neurosurgery, to follow the monthly seminars that my colleagues in pediatric neurosurgery are hosting. For example, that was their last one last July on DIPG. It was an excellent presentation with Michelle Mongi and Amanda Saratsis. And my partner, Mike Ivan, also hosts the very popular Miami Global Brain Tumor Symposium. I don't have the flyer for you for next month, but this was, for example, the flyer in June. So again, it is the first Wednesday of each month that we host this as well. For this session next month, you can see we have a wonderful panel on topics in endonasal endoscopy, anatomy, techniques, and outcomes with Maria Periselda, Albert Kim, Jim Evans, and Lee Zimmer. Again, those of you interested in skull base, in anatomy, and in endonasal and open skull-based surgery, please join us on September 16. Thank you for my team that makes everything happen so smoothly, particularly Ignacio for being with us the last year and a half and more doing these. These are some links if you're interested in viewing all the previously recorded sessions we've done the last year and a half, or to contact myself on Twitter or email, or the training coordinator, education coordinator, Ingrid. This is her email. You can see it there. And of course, we have an Instagram and a Twitter for the department as well. The format is, as you probably know by now, I have 4 internationally known speakers. I've asked each of them to speak for 20 minutes. At the end of that, my fellow David will present one case for their input. Then we will have the questions from the audience, and of course, we'll hopefully have either a debate or an interesting discussion between the panelists. So again, to remind you what is coming in the coming few sessions. So let me introduce briefly our speakers tonight. I will introduce them in the order I would like them to speak. So first will be my wonderful and good friend Bernard Bendock, of course, who is the chair of neurosurgery at Mayo Clinic in Scottsdale. Bernard is an accomplished open vascular, open skull base, and endovascular neurosurgeon, innovator, visionary, and will give us a fantastic title today. I hope the talk is as good as the title, The Road from Aruba to Paradise and AVM Cures. But you will be the judge of that. Bernard, always fantastic to have you back.
Thank you.
And I'll introduce all 4 of them now, and then this way I won't have to introduce later. Second, I'll ask Ali, who was a resident with us many moons ago, but has since then reached the stars in stardom. Ali is a spectacular endovascular and open vascular specialist, and he runs that program at the Brigham and Women and Harvard University in Boston. And I will tell him later when he joined us, Ali is originally from Afghanistan, and of course it hurts us all to see what is going on in Afghanistan, and we certainly hope for a smooth transition there, and we hope all the best for Ali's extended family back home. Third in line will be Jorge Mora. Jorge, who I've known since he was a resident back in the late 90s. Jorge has an enormous experience in skull base and open vascular. He is at the Institute of Neurosurgery, Asenio in Chile. I do believe Jorge probably, if not the largest surgical series of paraclinoid aneurysms, certainly among the top few. He has more than 400 such cases, and that's what he's going to talk to us about today. Jorge has been trained in Chile and did a very special time with our fantastic mentor and departed Evandro de Oliveira, and you will see the influence of that training in his philosophy and in his techniques. And last but not least, known to us as Kiko Gonzalez Llanos in Toledo, Greater Madrid area. Kiko is a spectacular microsurgeon in cerebrovascular and skull base, one of the most accomplished bypass surgeons there is as well, certainly in Spain. And Kiko is going to talk to us about the treatment of giant M1 aneurysms. So you can see we have a nice mixed bag of 2 AVM talks, 2 aneurysm talks, 2 duly trained neurosurgeons, and 2 purely microsurgically trained neurosurgeons, so that would always make for a fantastic discussion at the end. So I'm going to stop talking and I'm going to stop sharing my slides, and I invite now Bernard to share his slides and to talk to us about AVMs and Paradise.
Thank you, Jacques. Thank you. It's an honor to be back on your program, and congratulations on an amazing program. Let me see. Can you see my slides?
Yes, very well.
I just want to acknowledge Jacques for his leadership in our specialty, and really, he's the man who brings all of us together like he does on this program. Thank you for the honor. I have no financial disclosures. I have biases, of course, like everyone on this panel. And probably my biggest bias is I fear harming my patients. And this is an older picture, but our department, because of COVID, we don't have an updated one, but we've probably now doubled the size that you see here. And I want to acknowledge my vascular neurosurgery colleagues, and interventional neuroradiologist, Dr. Brian Chung, to Ali Turkmani, Chen, and Krishna. Also our vascular neurologists and our neuroradiologists, I should say, and radiation oncology. Our brain mapping team consists of a psychologist and a neurologist. This is their full-time focus, essentially, for brain with functional and tractography and intraoperative monitoring and mapping. And of course, our research team and clinical fellows and residents you see here, they are the heart and soul of our program. So I have a couple goals today. I'm not sure if I'm gonna get everybody to Paradise. It was an ambitious title, but I'm gonna dispute some commonly held beliefs. I'm gonna share some of my own biases and thoughts, and share some potential creative solutions that I would propose. My talk probably would need 3 hours to do it justice in terms of the ideas I'd like to share, but I'll try to do the 20-minute version. So we all know what AVMs are. You wouldn't be attending this program if you didn't know what an AVM is, but I pull up this cartoon just for us to think about the components of an AVM, feeding arteries, the nidus, and the draining vein as we think about AVMs. And I think it's important to think about these components when you think about natural history, when you think about effect on a patient, when you think about treatment. It's important to remember, I bring this up, just the incidence of AVMs, 11% of vascular malformations, 64% are diagnosed before the age of 40, which makes it the most important cause of hemorrhagic stroke in young individuals. This is an important idea I'd like to reiterate or just emphasize in that these lesions can harm, they can kill. 13% of patients who have an AVM hemorrhage are moderately disabled. 3% will have severe disability. and 30 to 50% will have a deficit after bleeding. There's a 10% mortality after hemorrhage, which may be an underestimate. The symptoms go beyond hemorrhage to seizure, mass effect, headache, bruit, steel, incidental discovery, of course, and an area that is not well explored, and that's cognitive impact. In children, we see hydrocephalus, congestive heart failure, and prominence of forehead veins. Posterior fossa AVMs are a special category. They're probably more impactful on natural history than supratentorial counterparts. They often present with hemorrhage, and they're often very morbid when they do present. AVMs are not static lesions. There's inflammation going on, ischemia, angiogenesis, hemodynamic stress. We tend to think of them as static, but they are not. It's a human bias because they change so slowly. Much like looking at a mountain, we tend to think of mountains as being, that mountains don't change, but in fact, mountains are changing all the time. I bring this up, the Spezzer-Martin grading scale up because just to review it very briefly in preparation for my just comments on Aruba, we all know this grading scale very well. So I'm going to divide my talk, focus for the next about 10 minutes talking about Aruba. This will not be a comprehensive discussion on Aruba 1 and the follow-up study from Aruba because we need a much longer time to really go into detail on this. But just to give you some thoughts, and mainly I'd like to plant some questions in your own mind about this study. First, I'd like to congratulate the authors for doing this study. I think doing prospective studies is very important in our field, and but at the same time, I think it's healthy to critique the study and to see what can we learn, what can we take away from it that goes beyond the headlines. And that's, I think, very, very important. Why is it important? Because we make decisions based on how we're impressed or not impressed by these studies. Society tends to make decisions based on these studies, and I think it's important to look under the surface. And so I want to bring this up because this was a premise in the introduction of Aruba. This is a quote. Furthermore, first hemorrhage syndromes are often mild, with bleeding often mainly confined to the brain arteriovenous malformation itself or originating from the venous side of the malformation, with an emphasis on the word mild. And I don't know, but I think at the University of Miami ICU and Northwestern ICU, I didn't see many mild hemorrhages. Obviously, that's a bias because we tend to see the sicker patients. But nonetheless, Dr. Morkos and I and all of you have seen people maimed by AVM hemorrhage and severely harmed and sometimes fatally. So I'm not sure if I would support, and this is sort of part of the introduction of Aruba. So right from the get-go, there is this idea that AVM hemorrhage is not that severe. And so what was Aruba? It was a study, a randomized study comparing medical management, best medical management, although there is no actual medical management for AVMs, but what they meant by that is managing the symptoms, because this was a study of AVMs that had not ruptured, but could have been symptomatic. In fact, more than half of them were symptomatic. And so best medical management, quote unquote, up against any type of intervention as deemed appropriate by the treating team at about 39 centers in 9 countries, all adults, randomized 1-to-1. So the treating team at these 39 centers could devise a plan that they felt was best for the patient. So it could involve embolization, surgery, microsurgery, radiosurgery, or any combination of the above. So it turns out that after randomizing, 109 went to conservative therapy, 114 to interventional therapy. That's how they were designated in the study, or that's how they randomized, but that's not necessarily what they had done. Follow-up was halted at 33.3 months because of worse outcomes in the interventional arm. The primary outcome, and this is interesting, and there has been much criticism in stroke studies of combining endpoints. Here they combine death of any cause and stroke, symptomatic stroke, into one primary endpoint. I find that myself to be a little problematic. I don't have enough time to go into the details on why that is, but I'll try to hint at it as I give you some more comments. Now, but it's very important to define, how do they define a stroke? A stroke is defined as a clinically symptomatic event. This is in the study. Any new focal neurological deficit, seizure, or new onset headache that is associated with the imaging findings of hemorrhage or infarction. So pretty broad. So if you do surgery on a patient and they have a hemorrhage that's called, let's say a post-op hemorrhage that could be small, maybe a small subdural or small hematoma in the cavity, that if that caused headaches, that would be counted as a stroke. Or let's say there's a post-op seizure that was attributable to the therapy, then that also counted as a quote-unquote stroke if it correlated with an imaging finding. You had a little diffusion restriction around the cavity, there was a seizure. The senior neurologist on the study adjudicated that to a stroke from the treatment. So I find that a bit problematic. So this is why the study was halted. The conservative group at 33-month follow-up, which is very short when you think about a 33-month follow-up for an AVM, is like looking at smoking and new onset smokers at about 1 year follow-up. That's my best analogy. So 11 patients had reached the primary endpoint on the medical side and 35 patients on the interventional side. So that was felt to be too high by the DSMB, and the study was halted. So which AVMs are we talking about? One of the problems with Aruba, one of the challenges, I should say, and I sympathize with the study team here, is that AVMs are very heterogeneous. Even if we classify AVMs based on Spetzler-Martin grading scale, they are very heterogeneous. 76% of the AVMs in the study were grade 1 and 2 Spetzler-Martin. 28% were grade 3 and 8% were grade 4 AVMs that we typically don't treat unless they've ruptured, in many cases. So that to me was a bit of a red flag. And why is it a red flag? It's even more of a red flag when you look at how these people were treated, which I'll get to in a minute. But these were the patients who were, it's very important to look at this slide because these were not asymptomatic AVMs. About half of the AVMs were symptomatic with seizures, headache, focal deficit, and other symptoms. So more than half were symptomatic in both treatment arms. And 54%, this is a very important point, 54% in the treatment arm were in quote-unquote eloquent areas. They define eloquent as sensory motor, language, or visual cortex, the hypothalamus, thalamus, internal capsule, brainstem, cerebellar peduncles, or the deep cerebellar nuclei were involved. So more than half were symptomatic, more than half were in these eloquent areas. So you would expect with treatment to have some detectable quote-unquote stroke, quote-unquote, based on their definition. The one thing I want to point out in this slide, this was sort of it breaks down the number of patients who were screened. We won't get into that, but of the 116 that were allocated to treatment, 22 did not receive treatment for reasons that were not clear to me from looking at the study. And there was some crossover, as you would expect. But how were these patients treated? And this is probably the most puzzling thing about Aruba. Only 5 received pure microsurgery alone, even though we know that microsurgery for grade 1 and 2 AVMs has relatively low risk. We know the great work of Dr. Hiros that even patients who develop a deficit post-op tend to recover. Embolization, 30 patients, radiosurgery 31, microsurgery plus embolization 12, embolization plus radiosurgery is 15. And we know that embolization plus radiosurgery is very controversial. And so it's a bit puzzling when you look at which AVMs were involved in Aruba and how they were treated. Only 5 had microsurgery. So this was not a study of microsurgery for grade 1 and 2 AVMs, even though grade 1 and 2 AVMs were the dominant represented cohort in this study. So when you look at the primary outcome, there were 3 deaths on the treatment side, 2 of which were AVM related. There were 2 deaths on the medical side. So there was only 1 more death on the surgical side, of which, so if you only look at AVM related, essentially it was a wash. If you look at stroke, there were 25 hemorrhagic strokes after AVM treatment. A bit, that's 20%, 1 in 5. I think if Dr. Morkos had that 1 in 5 hemorrhages, at least how we think about hemorrhage, and remember, any symptomatic hemorrhage was considered a quote-unquote stroke in this study. Ischemic, what if you're taking out an AVM in an eloquent area and you have a transient deficit, let's say a hand weakness, that would count as a stroke. But if the patient is okay at 3-month follow-up, that Aruba wouldn't capture that. This is probably, on the other hand, this is something that I didn't fully understand, but the risk of neurological disability at 30 months was significantly lower for medical management. You can't get enough, I think, out of Aruba from the data that's presented to really understand this. And this remains a question in my mind, but it is a red flag against treatment, at least against treatment as the way it was done in Aruba. So this is my problem with the study. Surgery and endovascular rate were all treated the same and left to the discretion. It would be like running a randomized study on antihypertensives and letting every doctor pick whatever drug they liked. How can you make a comment about any specific drug when you do a study like that? It's very puzzling to me. And when is a stroke, quote unquote, a minor stroke, a relatively good trade-off for AVM cure? If you have an 18-year-old with an occipital lobe AVM, and you resect that AVM, and you know you're going to cause a visual field deficit, is that a good trade-off for a lifelong protection from AVM hemorrhage? We could debate that. I know how I stand on that one, but certainly in Aruba, that would have counted as a bad outcome if you have a visual field deficit from AVM resection. So where is that balance, and where do we strike a balance here? And when does longer term follow-up, so if we give AVMs on the medical side 10 years, 20 years, at what time point does intervention start to beat medical fit, quote unquote medical approach? Some other problems with the study are low occlusion rates. About half of the AVMs were not occluded at follow-up. The causes of stroke, we don't have enough detail to know what are they talking about here. A headache from an imaging finding related to the AVM treatment, let's say a little bit of swelling after surgery, would that count as a stroke? It's really unclear and puzzling to me about how it wasn't very transparent to me. Adjudication of skill wasn't clear to me in this study. And again, is a stroke an acceptable trade-off? And causes of death were not entirely clear. So in the follow-up Aruba study with a mean follow-up of 50 months, we don't learn a lot more, but again, the medical side remains superior based on how they designed the study, although the number of people who followed up to 50 months was low. It was only about 40 to 50 patients in each arm who had followed up that long term. So in my remaining time, I'm going to shift gears and talk a little bit about some other biases. Actually, I'm going to skip this one just because of time. But again, the idea that AVMs are static. We tend to think of AVMs as homogeneous and static, and they are not. This is a 12-year-old who presented with this small AVM at age 12. He was advised radiosurgery at an outside hospital. You can almost miss it. It's in the premotor area here. It's a very small AVM, and it's almost hard to see. He was lost to follow-up, then came back to see us at age 18 with another seizure. I'll show you that now. And here he is now with an AVM that's impossible to miss. This AVM had grown dramatically in those 6 years. So AVMs are not static, even though we think of them as static. So when you get an MR scan that says an AVM is unchanged, I think one should be quite skeptical. And so what do you do with this one? He's 18, it's in the premotor area. To treat it, you are going to incur risk. So I would think that we should be putting more emphasis around innovating brain mapping. And this is something we're very passionate about. How can we advance our sophistication in treatment recommendations and treatment safety with brain mapping using both functional MRI and tractography? And we can get quite sophisticated with this. So this is that same AVM looking at the corticospinal tract as we make decisions and as we potentially offer treatment. We can get into 4D MRI and better understand the hemodynamics of an AVM. So to look beyond static data. This is just some work that we had done on this. And then in the future, I hope we can get into molecular imaging so we can develop red flags for risk of rupture so that we can look at an AVM beyond just what a 2D MRI can show, but could we look at metalloproteases, for example, in the AVM, look at what's upregulated, much like people look at brain tumors these days. What about natural history? We tend to think of AVMs as being homogeneous. They're all the same. They all have the same rupture risk. At least that's what it says in Greenberg. But we know from the literature that previous hemorrhage-associated aneurysms, involvement of perforators, infratentorial location, deep venous drainage, all can impact rupture risk. And I think what we need to do is to move from the population science era that we're living in now to the precision medicine era, using artificial intelligence, genetics, and hopefully molecular imaging so that we can individualize recommendations about AVMs and stop treating them all as being homogeneous. So when we think about treatment, we think about these three modalities, and I'm just going to show a couple AVMs in my remaining time to emphasize the point that when we think about embolization, that's not one thing. We have to be very strategic, and this is just a list of things that embolization means, and it means many different things. And when we think about embolization for cure, and I bring this up because this was used as a modality, remember, in about 30 AVMs in Aruba, we know from this review from UT Southwestern that embolization for cure carries a significant risk unless you're being very strategic about which AVMs to use this modality on. And so if you're at centers that are really pushing this for cure, you're going to have a morbidity, I think, that is not easy to justify. If you look at embolization before radiosurgery, That's also been debated in the literature, and the outcomes seem to be worse than radiosurgery alone. This is a controversial topic, but it was a modality or an approach that was used in a significant number of patients in Aruba. So something to think about as you analyze the Aruba results. Embolization for grade 4 and 5 AVMs. Not entirely clear how many of these were in Aruba, but remember on the treatment side, 8% of the AVMs were grade 4. So we know that when you embolize AVMs partially without intention of cure, you're likely worsening the outcomes. So that's another thing that you can go, as you read Aruba, you need to think about that. So when you think about embolization for cure, this is a 71-year-old gentleman who was not a candidate for surgery. He was on oxygen tank, but had a sentinel bleed from this frontal lobe AVM, very easy AVM to treat surgically. But I just showed this to you because if you're going to use embolization to cure an AVM, you have to be very careful that you pick AVMs with a compact nidus, limited number of feeders, and this was ideal for that approach. He wasn't a good candidate for anesthesia, and under mild sedation, we were able to catheterize this AVM and occlude it fully, and he has done well at follow-up with a permanent occlusion seen at 2-year follow-up. So my point is, if you look at Aruba, they were really pushing embolization as the prime modality, which explains why they had a low follow-up, poor occlusion rate, and higher morbidity than we would expect. I'm going to, just because my time is limited. Jack, how much more time do I have?
Bernard, maybe you can have another 3 or 4 minutes.
Okay, then why don't I just, what I want to show, I'm going to skip the radiosurgery part here. I'm sorry, I'm just going to skip a couple slides. I'm sorry, I underestimated. I'm just going to show really briefly, the young gentleman I showed you earlier, the 18-year-old with a premotor area AVM. We wound up embolizing him and taking him to surgery. He woke up with a weak hand, as you would expect from a premotor AVM like this. But at 6-week follow-up, even his fine motor function was intact. So in Aruba, he would have counted as a stroke. But he's now a decade later doing great from this AVM resection. I'll show you very briefly here. We took him to the OR, sorry, just to show you here. And we don't have time to show the full video, but we monitored his motor cortex and resected this AVM without any trouble, other than some mild hand weakness after surgery. And again, he would have been counted as a deficit in Aruba. This is a patient who presented with a seizure from this fairly small left Wernicke's area AVM. We wound up doing this awake because we wanted to resect the hemosiderin stained tissue around the AVM. So we mapped her brain. And in Aruba, this could have been counted as a stroke. She wound up waking up without deficit, but she had some headaches and did wind up having one seizure post-op, but has been seizure-free at follow-up without medications. But that would have been counted also as a quote-unquote stroke in Aruba. And the point of this was to show you some cases that would have counted as strokes in Aruba that actually wound up having a good outcome. I'll show one final case here so I don't monopolize the time here, Jacques. I'm sorry. So I want to show this case. I'll end with this case. So in Aruba, remember the claim was, the justification for the studies that many hemorrhages are benign. And I now have in my series about at least a dozen cases of these Vermean AVMs that present near dead in the ER. And I'm sure, Jacques, you have the same. And these are AVMs that had you seen a week prior, they would have been asymptomatic, and based on Aruba, you would have had a hard time maybe justifying treatment for. And these Vermean AVMs, when they present with hemorrhage, often present dead or near dead. And I call it the night of the living dead because they have these classic midline hemorrhages. They can present with hydrocephalus. And they typically have a very poor exam. But if you act very quickly and put an EVD in and take them to the OR and do a craniectomy, you can, and then take them to the angio suite immediately to follow. We found the rupture site in this case, closed the rupture site, and then brought the patient back in 3 months and treated the AVM. And the patient wound up having a great outcome and went back to work. And I bring this case up only because it's really problematic to be able to digest the Aruba data when you see great outcomes like this from microsurgery and combining microsurgery and embolization. And finally, in my remaining minute here, I'd just like to say a word about, I'm just going to skip this last case and just say a word just a couple of comments on the future, if I may, Jacques, here. I'm sorry, right after
Sure,
this.
no worries. No, don't worry. Don't stress. It's okay. Go ahead.
Okay, thank you. And I'll just go. Okay, so just a couple comments, and I'll end with some philosophical thoughts about the future of AVM management. I think it's easy to beat up on the Aruba study. Of course, I'm a surgeon, and if there are any neurologists in the audience, I apologize. Again, I want to congratulate those who did the study, but I think it's just important to look below the surface and look at the methods that were used in the study and what implications it has going forward, both for management, but also for future study design. And I would encourage all of us to be thinking about going beyond angiography and MRI as we think about these AVMs. Use 3D printing to better understand these AVMs, use holography to get really strategic and understand which AVMs can we treat safely and which ones can we not treat safely. And I would encourage us to be integrating therapies, not think of microsurgery as its own silo, but how do we very smartly integrate embolization, microsurgery, and radiosurgery? And when is it not smart to integrate? When is it not smart, such as, in my mind, embolizing followed by radiosurgery is okay in select cases, but has to be questioned in many cases. It's just an example of where, yes, we want to be synthetic, we want to be integrated, but we want to be smart about it. And I think until we get more deeper on AVM understanding, we're going to struggle with that. We are investing heavily in robotics here at Mayo Clinic. And when does it make sense to integrate robotics into our therapies to make our microsurgery even more smooth, even achieve greater finesse, much like prostate surgeons have done with the Da Vinci? Can we take Jacques Morcos's skills and take it even to the next level? We have to think about how we design our ORs to integrate the best of Embel's angiography with the best of microsurgery. We have to think about telehealth and intervening sooner. So when somebody has a Vermean hemorrhage in the field, we get them to the right hospital. They should go to an AVM center or an advanced stroke center and not to the wrong hospital, which can make the difference between life and death. And then in terms of accessing and studying AVMs, what kind of technologies do we need to develop to become even more elegant in terms of how we devascularize AVMs and what therapies we deliver? So on that note, I'll end. Thank you, Jacques, for inviting me. And I'm sorry my slides were a little bit bigger than the time allotted.
It's okay. That was a very nice tour de force, and at the very least, the young people in the audience read the passion in what you do and what the rest of us do, and that in it. But of course, your review of Aruba is excellent. As you know, it's traditional that we keep questions till when all the speakers have spoken. So to the audience, as I put, please put in your questions in the Q&A box. And Bernard and any other panelist, when you open the box, if there is a question addressed to you specifically, feel free to type in your answer to the questioner. Now it's my pleasure to have Ali. I don't know if you were there, Ali, when I introduced you earlier. I said that you were absolutely the worst resident I've ever trained. No, I didn't. It's a fantastic pleasure to see you, my dear friend. And please unmute your microphone, share your slides. And number one, our thoughts are with all your extended family and your friends and colleagues in Afghanistan, as I said earlier in my introduction. And this is tough times for Afghanistan. And number two, tell us what you've learned about AVM treatment at the edge, from the edge, as you said. Welcome, Ali.
Thank you. Thank you. Can you hear me?
Yes.
My dear mentor, my dear brother, thank you, especially in these tough times. It's always good to hear you. And it's always good to see you. And I am so grateful for all the things you've done for me. Allow me to share what I've learned from you and Dr. Harrows. Here we go. Can you see my screen?
Yes, Ali, it's excellent.
Okay. So just disclosure, I used to go around teaching these different techniques when new devices came around. So it gave me a unique perspective of how different people were doing, because as a proctor and you kind of are in their lab and you see some of these things, some friends and some people I met that way. Let's go back to the trajectory of endovascular. I was trained by the icons of neurosurgery, the Michael Jordans of neurosurgery, Jacques Morcos, Roberto Harros, Robert Spetzler. And so I came out very, very, very aggressive. And I had a unique skill set, I think, from playing video games. And so I became really somehow very good at this embolization stuff. And so I went to the edge. I was taught by I.J. Walkley, who I consider a virtuoso in the space. I've seen Moraes and I've seen guys at Barrow, and I knew where the edge was, and I was hungry to go there. And I just wanted to talk to you about the lessons that I learned in getting out there. And so let me take you back to the history of the beautiful field of endovascular and how it came about and how it intersected with our beautiful surgical field. So in the 1960s, Lucenhop was putting threads and so forth, and that's when embolization started. And little beads that he would make in his garage of different sizes to close pedicles. In 1970s, Serbienko, that Dr. Harros always talks about, invented these balloons again in his garage to sort of inflate and leave and close off pedicles to AVMs. Still garage material, right? And these few people that were doing it. And then the materials came around, the silk and the gel foam and the cyanoacrylate and the white stuff in Miami. People were injecting everything. This is Chuck Kerber that started injecting glue-like material using balloon catheters, stopping flow in the 80s and so forth. This is when we started to gain some momentum with embolization, and that was with butyl cyanoacrylate that you could sort of mix so you could control the flow and where it goes and how deep it penetrates. And all of a sudden, it became this, I'm going to take as much of this AVM, almost like a surgical mentality, like I'm going to get it all, or like a tumor resection. I'm going to go as far as I can. And the tools that were used to get you as far as you can started with this. You could mix it in different, and it would polymerize differently. And my friend Philippe Gaillou from Hopkins described injection techniques of glucose to change the polymerization. And then Onyx came. Onyx came right around the time that I had finished my first fellowship. And this sort of did the things that we were always expecting glue to do. It was this material that would just keep flowing and keep flowing. And if you were patient, you'd get it deeper and deeper and deeper and into smaller and smaller vessels. This is a paper by Shaker's group, and the type of vessels that this would go to compared to NBCA, which caused more of a fibrosis and a proximal occlusion. And then there's this back and forth again about, oh, you can't cut through this, and it's harder. And again, the surgeon endovascular back and forth. But I don't know why I injected both in this vessel, but it's the same. On the left was a cut through Onyx, and on the right it's a cut through NBCA. It doesn't really make a difference. The catheters advanced, injection balloons advanced, catheter technology and how far you could take them advanced. And so we were now gaining percentage of the AVM in a certain mindset, going towards a win, a cure by a specialty, by a modality instead of the disease. And there's different concepts and imaging characteristics of really studying and three-dimensionally understanding the AVM, as Bernard was saying, but also understanding the flow patterns using 3D images to compartmentally embolize and so forth. Other techniques that we talked about actually in children, I would hold down the jugulars and it would stop the flow, or manual compression. We even talked about adenosine for heart block. anyway, you could really control the flow of this material with coils and other sort of techniques. I'll just go through this. Went to France and watched one of Moray's groups talk about this 2-catheter technique. This is a grade 5 AVM that I took out. It's grade 5 because it was the entire visual cortex, and she was already. But you see this bottom picture. I felt like a cowboy. Two catheters injecting at the same time. Flow. This, was getting wild. And then papers and talk about transvenous embolization. I remember this isn't the new concept. This is an old concept initially described by Sean Mullen that Dr. Harrows would tell me about, how he would measure pressures in the vein and then slowly take arteries surgically and then close the vein. This isn't new. And I remember being in Link with Dr. Morcos and somebody talking about this. And when was that? 2004, 7, something like that. And Dr. Morcos almost amputated his legs, but he didn't out of graciousness. Anyway, this is coming back into favor. But we studied this. We studied this when I was in Miami. This is the pig rete, and maybe there is something to it, but it's got to be something more than percentage driven. Like, hey, I'm going to take the whole AVM. Maybe it's something what neurosurgical history taught us. Maybe it's measuring the venous pressures and actually starting to tailor your embolization to what's happening to the pressures, and that's what we were doing here on pigs. So I will tell you that there's different types of embolization that can look like it's cured. There's the nidal, where you can actually get deep into, and this is the school that I came from an endovascular side, just fill the whole thing, and you can almost see that there's only a vein left. This woman I was taking out the next day, and she hemorrhaged at 6 o'clock in the morning before surgery started, even being under anesthesia, and the veins were open. This is a pedicular injection. This is the old school embolization, where you actually take a vessel that you can't actually reach surgically, like this lenticular striate that was going there. But there's different concepts of embolization. Embolization, as you saw Bernard talk about, and even in my hands, who I think I'm pretty good at this, is morbidity somewhere from 9 to who knows. Onyx in my hands were around 9% per session when we looked. Mortality, this is additive. It's not necessarily making surgery safer if you're hitting these types of complications. And this is from the Turkish group, Shekerje, and all of these sort of advanced endovascular practitioners that I followed and were fans of their techniques. Personally, these are the types of complications that you can witness. This is me embolizing a SCA, and when I pulled the catheter, you see a piece of glue flies out, right? Here's my catheter pulling, there's the glue into the PCA, leading to a visual deficits. My contribution to Aruba. Here you go. Unfortunately for this poor human being. This was next to the motor cortex, and my part, it was embolized. And being a young, maybe not so thoughtful human being at the time, I said, you know what, I can do better. I can do better. What is this little puff in the air? I took this AVM and I embolized it like there was no tomorrow, because I thought it wasn't being adequately treated. And you can see, look at the bottom pictures, there's nothing left except for a vein. The vein's always open. That I was taught. This is a patient in Aruba. This is the next day. Massive hemorrhage, poor guy, young guy, paralyzed on one side of his body. So There's a lot. This one hurt the most. This is a woman that was a grocer. She loved to work. She would package groceries at the grocery store. Very wonderful lady, trusted me with her care, really studied this and went strategically, one pedicle after another pedicle, got the MCA feeders, then went to the PCA, as my mentor would say, that you have to lift the temporal lobe, and that PCA feeder will get you. So got into there, and you can see I cleaned it out. This is neembolizing from the PCA. Wake the patient up, and she's not moving. The material went from the posterior temple through the AVM and into feeders from the MCA and then into the M1, right? This is where the edge takes you. This is where your tumor resection sort of technique takes you. So this is not my ideas, but this is what I've learned from my mentors, Roberto Harros and Jacques Morcos, and some of the points that Bernard spoke about. Here are my indications after doing the extremes. My honest introspections come back to exactly what I was taught. So in curing with NBCA alone, with Onyx, depending on what you pick, is anywhere from 5 to 40%. But what are you actually picking? And if you pick an AVM to cure, like Bernard said, it not only has to cast the thing, but it almost has to go into the vein. And that with it can come with 20% risk of hemorrhage. That's from Moray's sort of series. And if you don't do that, if you do what I did here, and you can show this off and say, hey, I cured this, who's going to argue with that? That recurred on me, right? That looks like a great cast. It's not into the vein, but this came back. So yeah, here you can see. So when you can't cure it and you're taking an increased risk from the procedure and you're leaving a half-wounded animal, the risk of hemorrhage in the natural history's changed according to a number of different papers. Miyamoto on increased from a 2% annual bleed rate to 14%. So recommendations for curative embolization are very, 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 very limited. Deep locations, maybe advanced stage, but very limited indications. And the ones that you can actually cure are the ones that you can easily resect most of the time with very little morbidity. Partial targeted embolization, the times that we sort of recommend this, that my school of teaching recommends this, is like, this is a prime example, but this is a young lady that came to me in 2 months with 3 bleeds, or 4 or 5 months. This was also in Miami, repetitive bleeds exactly in this area. And if you look, she's got this small little aneurysm in a grade 5 AVM, thalamic AVM. So we went in and we dropped a point of glue right into that aneurysm, and she went for 4 or 5 years without another hemorrhage. And you can see that spot of glue where that aneurysm was. So partial embolization, maybe for treatment of a rupture point, if you can identify it, which is usually difficult, or palliative. This is what Dr. Harros talks about sometimes for intractable headaches or steel phenomenon. I've done it a number of times, not tons of times, and it's been 50-50. Sometimes it helps with intractable headaches or seizures, but sometimes it doesn't do anything. So I don't know about that. Recommendations for partial embolization, you saw there. Embolization before radiosurgery, not repeating Bernard, but there seems to be a higher recanalization rate from the parts that's been embolized, and therefore your overall treatment is nullified. So instead of radiating something, the material can recanalize or even block the correct treatment of that area. So it doesn't seem to do anything beneficial in the long term, but increases that risk. So you're taking the risk of embolization and the risk of radiosurgery. Recommendations for embolization before surgery. This is sort of, we go back to the classic reason of why it was done. And this goes back in history of a case that Dr. Harrods did with De Bruin at the time. And this is a brainstem AVM, and you can see this perforator going through. That would be, you'd have to chase it into eloquent tissue to sort of get it. And this is, I don't remember if this is 80s or so. And there was a targeted embolization, and then it turned surgical resection. These are Dr. Harrods' films. Made it essentially a surface AVM instead of digging in through chasing this vessel. And here's a cure picture of it. So recommendations for preoperative embolization include hard to reach pedicles, perforators, sometimes to reduce flow next to eloquent areas, like that one I did, but aggressively was next to the motor area. It's helpful sometimes to include dural or transcranial feeders, which can make opening and so forth dangerous. But always to keep in mind that the risk of embolization plus surgery should be less than the risk of surgery alone, that you can't just add on this extra risk just to make your life easier. It has to take into consideration what's the lowest amount of risk for that patient. And again, this data is very, very, very hard to beat. You know, grade 1s, 2s, and 3s, very low morbidity, very, very low mortality. So final points, the natural history of AVMs, 2 to 4%, risk of embolization alone or multi-modality treatment should never exceed natural history, and individual patient tailored decisions with a team that is transparent and not siloed and can honestly talk about what they can and they can't do without bravado, and honest introspection of your own skill set and your team's skill set in order to deliver the best level of care. Thank you very much.
Thank you, Ali. Always the most honest talks, along with your skills, are given by you. I actually remember very well when Jacques Moret, remember when his fellows more than 10 years ago presented his own morbidity of AVM embo. It was close to 20% per session at the time. And he was certainly very honest later on to say, well, he doesn't embolize unruptured AVMs anymore. And it's interesting to see with your extensive experience where you stand today. And we'll open it up for discussion later. Thank you very much, Ali. Jorge, let us have you talk about paraclinoid aneurysms and your microsurgical experience with that. And I am sure our two colleague endovascularly trained neurosurgeons will have their opinions about that later.
Thank you very much. Well, for me, it's a great honor to be here with you today and try to talk something not new, but new about the paraclinoid aneurysm based in 20 years experience in the subject. I think that the previous two lecturers before me, that it's very important to try to put some modern thing in the practice that we do about the patients, and try to offer to the patient less morbidity, less mortality, and better results. Not just to be after a technique. We need to offer better results. And I want to share with you something personal of me, because I'm very proud. 1 minute only, because Jack going mad when I talk too much. But for me, it's a great honor because I was appointed recently as the 4th Master of Chilean Neurosurgery of the history. The 3 neurosurgeons for me are, of course, passed away, and all of them were appointed after 70 years old. And you don't know, but I am 50. And I'm very proud about this. And in my city, even in my city when I was born, they put me in the journal of the city newspaper, in the cover, because this is a very important honor in my country. I'm very grateful. And this is because I teach. That's why these activities are very important, to share the knowledge in between us, because be just a good surgeon is not good enough. That's why all the people who are here today, I think, share the same philosophy. It's not only be a good surgeon, the goal that you must achieve. This is for the young neurosurgeons, young doctors. And you must try always.
Sorry, Jorge, by the way, I forgot to say you're also the president of the Chilean Society of Neurosurgery.
Yes, in 2 months. In 2 months, I will be the president. Now I am the vice president.
And then you can die happy. Then you can die happy.
Yes. Yes. Too much. I said to my fellows that they're going to kill me, actually, because when they appoint you like a master, you only need to die. You have nothing else to give. And I hope to give more. This is my conflict of interest. I like Jack said, for me, I was very lucky to be with Dr. Evandro in 1998, and Elder Tedeschi, who is a very good surgeon who teach me a lot in the operating room. And the most important thing is about neuroanatomy. Neuroanatomy is the key to answer our questions about what we're going to do with the pathology of the patient. And this slides from Elder, a dissection from Elder. And here is the key for the paraclinoid region pathology. Today, we're going to talk about the paraclinoid aneurysms, of course, but the philosophy you can apply for everything, for meningiomas, for chordomas. You can see whatever you want here: extradural, subdural, posterior fossa, middle fossa, anterior fossa. That's the very important thing about neuroanatomy. I think that in the pathology, you must pick the approach for the patient and the treatment you need to do based in anatomy, not try to put the patient inside the knowledge that you have. You need to do the tailored approach for every patient. If the tailored approach is endovascular, it's okay. If the tailored approach is a minimally invasive, it's okay. If the tailored approach is a huge surgery, it's okay. But you need to learn in the years that you're going to follow neurosurgery, the way to do the things properly for each patient. And the neuroanatomy is very important. We must be fair. You know that I got a great influence from the Japanese. And the first one who described the technique that we use based in our approach is Hakuba. Hakuba in 1982 published the extradural pure clinoidectomy. 1 year before Vinko Dolens. Even my dog, like Jack knows, named Doleng, my 13 years old dog is Dolens. But the first thing is that the Hakuba described the technique first. And it's very important, the neuroanatomy. The neuroanatomy, like I'm going to repeat this a lot of things, a lot of times today, is the key for everything. You need to, if you want to clip an aneurysm or not to clip, you must know the neuroanatomy very well. And today we have no excuses, because 20 years ago, you need to use imagination. But today you have 3D angiotomography, 3D angiography, MRI, everything. You have simulation, augmented reality. Today is much easier to can tell about which part of the skull base is located an aneurysm. And the other thing, you must be very fair with the history of my pathology. The history, why, for example, Drake made the intradural craniodectomy, or why Dolens made the combined, or why the Japanese made the extradural craniodectomy, because are different neuroanatomical concepts. It's very important that. And this is the picture that I took from a paper of 1999 from Dolens, and you can see there the combined technique. In the combined technique, you made a mini pinning of the middle fossa. You exposed B1, B2, the clinoid segment, but you need to split the sylvian fissure, because you're going to take the clinoid in the last part using drilling. And it's very important when you use the intradural craniodectomy, you need to split the sylvian fissure because you need a space. When you do Just extradural cranioidectomy, you don't need to open the Sylvian fissure. You don't need it because you're going to use the extradural corridor as the key of your surgery. And this is the original paper from Hakuba. He described the lateral wall of the cavernous sinus surgery, the Parkinson triangle opening, the extradural anterior cranioidectomy, and for who doesn't know, he described the first description of transpetrosal approach known as Kawase approach. Kawase described in 1985, and Hakuba described in 1982 in this paper, 3 years before Kawase. It's the same, anterior petrosectomy. And this is our paper from the year 2000 that we published in my country about the technique. I read all the time this paper, and is up to date. Is still valid. We made the same surgery, but today we apply the minimally invasive concepts. We have more than 400 now. I think 415 aneurysm now, because you know these 2 years the volume of surgery in my hospital decreased a lot because of the COVID, of course. But we still keep operating some cases, elective cases. And the very important thing, in 15 years I didn't change. I used the classic technique from 1999 to 2014, and I changed it to 2015. When you change to minimally invasive, you need to know why you change. You're not going to change for nothing. The first thing, you need to have influence. You need to follow somebody. You need to follow the principles of some people. In this picture, we have a Dr. Edgar Natal from Mexico, who was the first one who described the mini-pterional craniotomy, and Everval Gadelia, who was a fellow of Spetzler, and he described the mini-pterional approach that we used in our surgery. And why you treat the patient? Of course, you treat the patient first because you need to help the patient with something. In the paraclinoid, for me, the compromise of the optic nerve is surgical all the time. The optic nerve. For me, the optic nerve is surgical. The other nerves we can discuss about the endovascular, no problem. But the optic nerve is not a nerve. You need to decompress. And the other thing, you don't need always to take out the clinoid. Only in 80% of the cases, you need the clinoid out. Sometimes you don't need it. You just can clip or treat the aneurysms without clinoidectomy. It's not needed. But when you take out the clinoid, it's for what? To have the whole picture. You need to know the clinoid segment, the proximal neck, the distal neck, and all the picture in order to treat the patient and decompress the optic nerve. That's the key of the surgery, the decompression of the optic nerve. The revascularization techniques that people talk a lot about the paraclinoid. In our series, only 8% of the cases you need some kind of bypass. And then, what's the message here? You need to be a master in clipping first to be a master in revascularization. And the other thing, use the technology. Use the IC green, use the best microscope that you have. And it's very important always try to see more than you can see with your eyes. In this case, this bilateral paraclinoid, the important thing in this case was not the clipping of the aneurysms, is the preservation of the superior epiphyseal arteries and the irrigation of the optic apparatus. And then it's very important to use the technology. Important to use the flow when you treat this kind of patient, mainly when of course you have revascularization. This is the flow meter of Charbel, a very good friend, very good neurosurgeon. And of course, the results depend on the experience, but we have morbidity, we have mortality, we have problem. And the message here is when you have a rupture paraclinoid, it's an emergency treatment because the results in the rupture paraclinoid, if you don't treat at once the patient, is very bad, high mortality. This patient rebleed a lot. And the other thing, the neurosurgery developed day after day. We have new clips, new appliers. These Peter Lasik low profile clips are very good, but now we have these new clips that they name D clips. I think one of the best designs that we have today, and it's very good for this kind of surgery that we're going to discuss today. The minimally invasive, you need proper instrumentation, you need low profile clips, you need suction irrigation concepts, you need special rangers to take out the clinoid. You cannot use the same instruments to a classic surgery in order to do a minimally invasive surgery. This is a transition patient that we operate. You can see this transitional cavum or superior epiphyseal artery aneurysm. And in this case, we made a pterional approach extradural surgery. But the important thing about this is you can, when we clip the patient, we open a small opening in the dura, and most of the craniotomy I didn't use it, and I start to think why I did this huge surgery if I don't need it. This is the postoperative CT angio, is everything okay? And then we change. And I changed because my fellow said to me, Dr. Mura, is too big the surgery. We can do a little smaller the surgery. I said, okay, we can try, but when we have to be careful because the morbidity and the mortality are very important. And we start to change, but we change because we start to use this suction irrigation concept from the Japanese and the new instrumentation, new clips, you know, in order to have a small opening, but safe opening, because the result is the most important thing. And we base in this I show you the mini-pterional approach, and we start to publish. We operate, of course, we treat paraclinoid with this. We published it in 2020, the last year, the technique. We put the name extradural mini-pterional approach because the description original from Spetzler and Figueiredo is the mini-pterional classic one. Is anatomical, minimal invasive concept about the pterional, but this one, the difference is we use the extradural corridor. What is the extradural corridor? The middle fossa as the way to get the aneurysm. Ali Krish talk a lot about this when he operated the basilar tip aneurysm using the cavernous sinus as the highway, or in the case of the meningiomas. This is very, very interesting. And this is the anatomy, of course. We always follow the anatomy. This is one of my fellows that made a fellow with Dr. Roton, the only Chilean. Tomas Poblet is the name. And we prove that you can have a very proper exposure. And we name the mini Hakuba approach. The mini Hakuba approach is an extradural mini-pterional approach, and with anterior cranioidectomy, pure extradural, no drill. It's very important, the concept of no drill. All the people said to me that the extradural is dangerous because you can make a lesion in the carotid or the aneurysm. We have, I think, 200 or 250 in tumors. We never have a rupture in a normal carotid artery. And in paraclinoid, in the 350 maybe cases of cranioidectomy, we have 2 ruptures. And the only ruptures are aneurysms that have a clinoid segment portion of the aneurysm, transitional. Now with the angio-CT, modern angio-CT, you can tell before the surgery. And then it's not a problem of the technique, it's a problem of me as a surgeon, that I don't have a good pre-planning of the surgery. It's not dangerous, the technique. It's dangerous when you apply a technique in a patient that is dangerous. And then the change, you don't need 20 years to change. In this case, this is the same patient operating one side with supraorbital approach and the other side mini-pterional. Why we pick the mini-pterional instead of the supraorbital? Because in the mini-pterional, you don't open the frontal sinus. And in a scalp-based surgery, avoid the CSF leak is very important. And then we change the thing in order to have a less invasive approach. We start with this in 2015. Of course, we published the anatomy of that is the basis of the technique. And of course, we try to share the concept of extradural or key exposure concept that I try to put a name in English. Is keyhole surgery is just the size of the craniotomy. But when you have your craniotomy tailored to the size of the disc exposure, I try to put this name key exposure because it's an endoscopy concept. The endoscopy concept you have, if you use microscopy, you have the microscope here. But when you say endoscopy, the cella turcica is your operative field. It's very interesting, the concept of endoscopy. And then, for me, it's very important to show you this. This is the visual impairment, because this is very well studied for the Japanese, and the problem of the drilling of the optic canal. The drilling of the optic canal have problems in paraclinoid because the heating is something you cannot avoid when you use drilling. And this is a paper from Rokuya, 20% of problem of the optic nerve. And this is recent study. The Kamiyama is among one of the authors, and he showed that the visual impairment is related because they compare no drill with drill, and no drill is much safer. I know that because I use no drill, but the no drill must be very, very, very standard technique. If you don't use the same technique always and safe instrumentation, you will have trouble. And the instrumentation I showed you again is very important. The clip that you use, for example, this is the case only to show you that it's not a matter of the size of the aneurysm. It's the matter of the instrumentation that you have. This is a mini-pterional approach in this patient. And then let me, if I can move this again, I have the problem here. And if you follow the principles of a good surgery, distal exposure of the aneurysm, proximal exposure of the aneurysm, proximal control, distal control, decompression of the optic nerve. If you can put a retractor, you don't have any trouble to treat the aneurysm, because it's not about the size of the craniotomy. It's about the technique that you're going to use. It's very important. We always expose the neck, and this is a huge aneurysm, posterior wall aneurysm. We detach from the cavernous sinus. We expose all the neck, and if we use this specially designed clips named giant clips, you can clip without any trouble, and you can decompress the third nerve. This patient presents with a third nerve. And then the technique, I'm not defending something that is crazy. No, the only thing I'm telling you is you don't need always a huge surgery for a patient. You can use a tailored surgery if you have a proper instrumentation, a very good neuroanatomical knowledge. This is the postoperative angiosity of the patient. And the other thing is the teaching. The teaching is very important. This is one of my best fellows, named Ivan Perales, when he take out his first clinoid, anterior clinoid. The face of him tell everything. If you are just a good surgeon and you don't teach, it's not good enough. And this is another case I'm going to skip for a reason of time. Mini-pterional again, and you can properly open the sylvian fissure completely, expose completely the aneurysm in a mini-pterional fashion. No problem. You have proximal control, distal control, suction decompression. You can see the clipping, the ophthalmic artery, the optic nerve, everything okay. And the postoperative angiosity. Rupture aneurysm, the same. When you have a ruptured paraclinoid, you don't need to move the frontal lobe. In this kind of surgery, you don't need to move the frontal lobe because it's extradural. You expose the aneurysm and you clip without moving the frontal lobe, and there's no problem. Here, we open the dura mater, a small opening, we clip the aneurysm. After they clip the aneurysm, we open all the dura, cleansing the cisterns, open the lamina terminalis and everything. And the patient did well. The relaxation of the brain at the end of the surgery. This is the angiosity that we did after the surgery. And then it's very interesting to try to modify the teaching of our masters in order only to do a less invasive concept. And you can go a little bit further. And then we designed this keyhole approach. The real keyhole or the micro Hakuba approach. I'm going to finish with this. And then we designed this for decompress the optic nerve for tumors, the tuberculum cell meningiomas. But after that, when we made the dissections with Roton, we can see that the ophthalmic segment of the carotid artery is very well exposed for a keyhole. And then we said, why we don't apply this concept to a small aneurysms? We designed rangers, carries on everything in order to have good instrumentation for this. The clip, of course, and this is the cases where we operate. And these cases, the alternative for the patient is endovascular, flow diversion, for example. But if you talk with the patient and you offer to the patient a minimally invasive procedure, the patient can decide, I want endovascular, I want microsurgical. In some cases, the patient decide to have a keyhole approach. And the keyhole approach is very small. You can see the opening, and you can safely clip this kind of aneurysms. This is the video I'm going to skip because we don't have time. But in this case, in this video, you can see the clipping of this case, good decompression of the optic nerve, and you can cure the patient. The neurosurgical techniques evolve every day according to the necessity to offer less morbidity and better results. Some techniques are here to stay. Nevertheless, we can modify our master teachings, what I told you before. We are inventing nothing. All the things that we do, all are described. But you need to know who copy. You can copy good things for a lot of people and came with something that is good for your patients. I'm very grateful with my fellows. Now we have 48. And the last time we have a Latin American Congress in Chile was in 1998. That I was very lucky because there I knew Professor Jasarhill and Dr. Evando take me to my country to be with him. And we invite you all to Chile in 2024. We will have the next Latin American Congress. Thank you for your attention.
Jorge, thanks so much. It's always interesting to see how we all evolve different techniques with time. You've heard Ali talk about his story with endovascular, your story, and it's an ever-evolving story. And again, we'll save questions for later. But thank you for number one, staying on time, and mostly for your vast experience with this. Last but not least, I invite Kiko, if he is still awake in Spanish time from Spain, to share with us the very simple problem of giant M1 aneurysms, correct, Kiko? Really simple, those cases. Okay, looking forward to your presentation.
Okay. Now I'm talking about a very simple topic, as Jack Marcos said, the M1 aneurysm. Why are they so dangerous? Maybe because of the perforators and the angulation of the vessel and the difficulty in proximal control, many things. It's a very interesting topic, I think. And the first thing is that they behave like fusiform aneurysms. Giant aneurysms in M1 segment behave like truly fusiform aneurysms. We classified a long time ago the fusiform aneurysms into types. Type 1 without perforators inside the aneurysm, and type 2 with perforators. All M1 aneurysms would correspond to a type 2 aneurysms without perforators. The treatment in the first type of aneurysms, the type 1, it's very simple. It's trapping plus bypass, or now we could consider an stenting or things like that. But in type 2 with perforators, with always in the M1, we've been reluctant to use flow diverters in this segment. So we need, and this would be my target. My objective in this talk is to share with you the principles of to treat these aneurysms. I think we need bypass, we need proximal or distal occlusion, you will see, because we can redirect the flow or interrupt the flow inside the aneurysms by proximal or distal occlusion. Distal occlusion, we will talk about this technique. It's always stressful for the surgeons. It has the advantage, we don't need the proximal control, very difficult in these cases, but there is always a progressive thrombosis afterwards. We will see when we use this technique, and it's always a problem. We don't control the rate, the rhythm of this thrombosis, and things can do happen. But it's very important in this M1 aneurysms. Of course, all M1 aneurysms are type 2 with perforators. So we need, in this case, is proximal occlusion, proximal or distal occlusion, occlusion of the M1, bypass, of course, before. And it's very important, we need to decrease the size of the aneurysm because of the thrombus. We need to, if possible, remodel or at least partially occlude the aneurysm, depending if we do it, if we operate, we try to remodel it. If we embolize, we try to decrease the volume of the aneurysm. Our experience in these pure M1 aneurysms would be 15 pure M1 segment aneurysms. We consider pure M1 those confined only to the M1 segment, not going beyond the lumen insula and bifurcation, not going proximal, the ICA bifurcation, and 12 mixed aneurysms. These are truly bifurcation aneurysms going down proximally into the M1 segment and involving perforators. The types of bypass we've used are STA-MCA in 14 cases, ECI-MCA with radial grafting in 10 cases, and then the ACI-MCA with saphenous vein in the 3 cases. It's important for me that you get the idea that we are using more and more the STA-MCA. As you gain expertise and confidence with the bypass, you realize that for this, only for revascularization of the MCA segment is more than enough the STA bypass. And these M1 aneurysms, I don't know exactly what is the reason why. These giant M1 aneurysms, I have clear, they have more risk of bleeding than giant aneurysms in other locations. It's very important to know that when you receive a patient, even slightly symptomatic with a headache or a epileptic seizure, something like that, and you see in the CT scan or the MRI or the angio partially thrombosed aneurysms is a situation of danger. The metaphor will be here like the sulfur smell of a volcano. You know it's about to explode. And we had 3 cases, unfortunately cases, bleeding the night of admission before we could operate on them. 2 of these patients died before going to the OR, and fortunately we are able to operate the 3rd case. But it's amazing the risk of bleeding these aneurysms have. When it's too late, when they bleed, it's usually too late. Because you see, we received 3 cases bleeding before the night of admission, and we could only operate on 1 of them because these are huge aneurysms, and when they rupture, the bleeding are usually huge bleedings. This is our results. We have early permeability around 85%. And then 5 cases of late asymptomatic occlusions, mortality around 7%, and morbidity 25%. If you see, we had 4 cases with bypass not permanent after the patent after the surgery, but these were in the 3 of these 4 cases were cases in which we don't occlude the proximal M1 segment. We only remodel the vessel. And so in these cases, nothing happened after the surgery. But in 1 case, we had problems with an ischemic event, and we had to redo the bypass. This is the typical image, the typical scenario we have with this kind of aneurysms. You see a pure M1 aneurysm proximal to the lumen insula and the MCA bifurcation, and we can see a small free segment of M1 segment distal to the aneurysm. We need to take into consideration some anatomical consideration in the M1 segment. The perforators are in the inferomedial aspect of the artery. The dorsal face of the artery doesn't have perforators. It's free of perforators. It is very important when we remodel the artery. It has a variable length. Sometimes the M1 segment is very short. Sometimes it's very long. It might have different angles. Sometimes it comes straight to you. Sometimes it has an inferior or superior convexity. Whenever we have an aneurysm, it's always deformed, but in some way it preserves some of the original shape, the concavity, superior, inferior, whatever. And we have to know that before the surgery. Always to expose the M1 segment requires more osseous drilling. We have to be very aggressive with the sphenoid bone. And sometimes we even perform an OC craniotomy to gain more ability to put clip from anterior to posterior. And in these cases, with huge aneurysms, with an artery coming direct to you from inferior to superior, it's very difficult, the proximal control. Most of the times we have to start controlling the ICA, and then once we can diminish the volume of the aneurysm with trapping of the aneurysm and puncturing it, we're able to go this more distally. You will see now. We consider 2 types of M1 aneurysms. Pure M1 aneurysms, totally confined to the M1 segment, distal to the ICA bifurcation and proximal to the MCA bifurcation. And then what we call mixed aneurysms. These go beyond, starting the M1 segment, but go beyond the bifurcation. Most of the times, these aneurysms are regular bifurcation aneurysms, but with proximal extension. So we have to consider them in the same group for the treatment, like the pure aneurysms. So, and these are absolutely different of those aneurysms going proximal from M1 proximal into the ICA, because these have different considerations. We have to control the ACA coming off the aneurysm in these cases, and many times the anterior choroidal is involved in the aneurysm. So it's absolutely different. We only consider pure M1 aneurysms, these pure aneurysms of the one or the ones starting in M1 and going beyond the bifurcation. The most important thing in every aneurysms, but especially in these huge M1 aneurysms, would be the proximal control, the exposure, at least the ICA, to have a proximal control. And it's very difficult to achieve. It's very difficult to get to the M1 just proximal to the neck of the aneurysm, because it's hidden by the huge volume of the aneurysm. So we have to control the ICA and the ACA too, do the temporary clipping, trap the aneurysm, and then reconstruct it is what we do. We reconstruct and occlude the aneurysm, occlude the vessel just proximal to the aneurysm. This is the first case I present. This 35-year-old male with headache and seizures. And in the MRI, you can see a huge M1 aneurysm, partially thrombosed. This is a risky situation, I told you. When you see a symptomatic patient, a recently symptomatic patient with a huge thrombus in the aneurysm, is a risky situation. In this case, it was an old case. We decided to use a proximal occlusion with coiling and previous bypass. The considerations with this giant M1 aneurysm is that large size, difficult to get the proximal control. And in this case, for this reason, at that time, we chose the endovascular with previous bypass. In this case, we couldn't use the STA because of the size, and we decided to use the radial artery. We performed a bypass from external carotid using radial graft to M3, M4 MCA branch, and you see what happened. Just after putting the bypass, because of the slowing of the flow, because of the flow competition, there was a decrease in the size of the aneurysms right after the bypass. And then this is the bypass, you see, it's enough in the M3, M4 transition point, is more than enough. And then we perform the coiling and the occlusion. It's very important. It's not only about occlusion, because if you leave this huge aneurysm, you can't control what is happening inside. The thrombosis sometimes could be very dangerous, but you can not only coil the aneurysm to decrease the size without occluding, because the aneurysm will get bigger again, and it's a problem. I will show you a case later. So in this case, we did both, and the patient did very well. And this is another case. This case is a 45-year-old male presented with ischemic events, another way of presentation of these aneurysms. This is not a pure, this is a mixed aneurysm going beyond the bifurcation. It's actually a bifurcation aneurysm, but going proximal to the M1 with involvement of the perforators. In this case, we plan with our endovascular colleagues a bypass. In this case, we use a vein. This is the problem with this aneurysm is the perforators coming off the aneurysm. Impossible to trap, even with bypass. And in this case, we decided a bypass using a vein. Here you have the situation. And in this case, we perform only a distal clipping of the aneurysm, leaving the proximal patent. You see right after the surgery, you can see because of the not only the bypass, because it's cut the flow to of the bypass to the aneurysm, but because of the distal occlusion, we cut the flow inside the aneurysm, and it's almost gone. 24 hours later, in the angiography suite, you can see there is only a small remain of the aneurysm, and our endovascular colleagues decided not to touch the aneurysm. And 2 months later, the aneurysm has gone. It was a lucky case, but at that time, I still had 2 questions with this kind of distal clipping plus bypass. Do always aneurysm occlude using this technique of distal occlusion, or maybe there are some aneurysms that won't occlude? And the other question is, what is the rate of occlusion, or what kind of situations would be safe to use that? We don't use this kind of distal occlusion when there is an early blanch. In other words, a big artery coming off the aneurysm, never, because you can occlude distally, but there is still flow from the early branch, and it's pointless to do this because the aneurysms will be open. And the other situation in which never use this technique with rupture aneurysms or with irregular shaped aneurysms with clear weak points, blebs in the wall before in the angio studies before the aneurysms, but it's an option. I'm going to present a case tree, a huge mistake we made, and we learned a lot from this case. 67-year-old female presenting with headache increasing in the last month. And she has suffered prior to that epileptic seizures, but has not been diagnosed by of the aneurysms until he had the headaches. We saw this pure M1, a huge aneurysm, very regular, but with mass effects and with a lot of perforators coming off the aneurysm. In this case, we decided to, the STA was small, we considered it too small. This patient didn't have good radial arteries, and she has a very bad vessels. So we had to go to the groin to take out the saphenous vein. This is the distal dissection. You see, this is the typical image again of a pure M1 aneurysm with a small free segment distal to the aneurysm before in this case, the trifurcation. We performed the bypass with the vein. In this case, the problem using this huge graft, there is a discrepancy. It's a different, big difference inside between the donor and the recipient. And look at what happened. 24 hours, we planned the first mistake. We leave the embolization, it was not available at this moment until the next morning, and we did embolization the next morning, 12 hours later. And when we repeat the CT scan, the aneurysm was growing because of the bypass. The bypass was winning the flow competition. Here you have the sequence of the CT. And the problem is that the bypass was winning the battle of the flow competition to the ICA actually, and was putting blood inside the aneurysm, and we couldn't control that. It was a big mistake. And the second, then we made the second mistake. We put coils, but because of the we thought it was impossible to control the perforators if we occlude we didn't have a clean segment of M1 to occlude the vessel. And we did only 2 of the things, the 3 things we had to do. Putting coils to decrease the volume of the giant aneurysm. We put the bypass, was patent. maybe a little big for the situation, but it's a matter of time if readjusts to the needs. But we didn't occlude the artery. And what happened? Very fast, in 24 hours, you can see the coils started compacting. And 24 hours later, you see. We have even more compacting of the, and what happened was that the aneurysm exploded. And the patient died. So we learned 3 lessons here in this case. 1, we should occlude the aneurysm right after the bypass. We knew beforehand that these aneurysms with partially thrombosed, with a headache, sudden headache, worsening of a prior headache in the last week, it's always an emergency, maybe not tonight, but tomorrow morning or something like that. The second thing we have, of course, to occlude, to proximally occlude, to redirect the flow or cut the flow inside the aneurysm, preserving the perforators. But we have to also to decrease the size of the aneurysms. What is the problem of the coiling? The coiling is it comes with mass effect to the patient, and sometimes Ali can tell us later. It's not that easy to control of the perforators. To have that's why we feel, if possible, and in experienced hands in these cases, it's wise to try to do everything in the OR surgically. I'm going to show you this case, 37 years old, transferred to my hospital with subarachnoid hemorrhage. We operate this case in an urgent, as an urgent case, of course. You can see a large M1, very nasty aneurysm with irregular wall, several points of bleb, of weakness of the. In this case, you can see both branches of the STA are fit perfect for the bypass because they are almost 2 millimeters. And our surgical planning in this case was perform a double STA MCA bypass because we feel it's very easy, very low risk, and we prefer to have both. We get more flow. In the last years, we realized that we get more flow with a double barrel with a single bypass. And if something fails in one vessel, you have the other. Sometimes they compete and one of them occlude, but it's nevertheless is still open. We did first we did the STA anterior branch anastomosis to the upper M2 trunk. It's always the same. We try to we mark the vessel with methyl and blue. We open the vessel with a knife, then enlarge it with a scissor. We try to get a clean field with a hidden suction device, aspiration. And then we do the anastomosis, running suture the regular way. Everything should be clean. You have to protect the brain. Again, you have to be, in this case, we only stitch one of the ends like Jack Marcos usually do, because you control everything you are doing. I will run this. Again, we finish this, and then we control with ICG, with Doppler, with everything. We have the first bypass. Then we go to the next one, the STA, the posterior branch to the inferior M2 trunk. In this case, we use the same technique, but in this case we put, it was very easy, this bypass, and we're using the same technique. You see, we run the posterior suture, then we finally upon the second end stitch, and then the anterior wall, the same. And then we will move to the really important part of this surgery. Once we have the bypass, we check everything, both with everything. And now we go and get try to get the proximal control. This is the ECE and ACA, excuse me, and then is the ICA, because we don't have access to the proximal M1 yet because of the size of the aneurysm. Now we are dissecting the distal M1 segment, and then we put the proximal temporary clip on the ICA, and then on the ACA, then we put the distal clip, and now we puncture the aneurysm to try to collapse the aneurysm as much as possible. Remember the anatomical concept: perforators inferomedial, dorsal side, nothing happens. So when we remodel this segment of the artery, the M1, we always try to work on the dorsal side. Now we puncture the aneurysm, we lower the aneurysm to be able to control the perforators. To start, we try to diminish the size of decrease the size of the aneurysm. We use bipolar coagulation too, and many times it happens this with large aneurysms. We have to repuncture the aneurysm to be able to collapse it. So we are starting to see the perforators in the inferior medial. We have total control of the perforators. With this technique, we can see almost all the perforators. This is very important. And now we start.
I'm sorry to interrupt you. Can you maybe finish maybe in 1 or 2 minutes, if you don't mind?
It's only 1 minute. Now you see that we reconstruct now we put the temporary clip and start reconstructing you see, the aneurysm. And very important, we put the one clip to occlude the aneurysm proximally. This one, let me show you. This is very important. We remodel, but now you see, we put one clip in the proximal neck of the aneurysm, very proximal to occlude in a perforator-free segment. You see the perforators? This is very important. And then we have the aneurysm reconstructed, and right after the surgery, you have this. Look at this. This is an ICA injection. You see the cut here, the stop, where we put the occluding clip, and then we remodel this to avoid any kind of thrombus, and you see all the perforators. This is a blow-up view, you know, and then in this, after the surgery, you can see our bypass. Only one of the branches patent. The other is open too, but this is gaining the flow competition battle. So this is the situation. All the perforators, you can see all the perforators, and you don't have problems with the mass of the aneurysm. For us, this is the ideal treatment. Bypass, reconstruction, and proximal, very, very proximal occlusion. The conclusions will be that bypass is required in this case, in these cases of M1 aneurysms, even as a prophylactic. Even when we plan to reconstruct without occlusion in smaller aneurysms, it's wise to consider prophylactic bypass, very low risk. Proximal occlusion with side reduction with clips or coils. If possible, in our experience, remodel with clips better than coiling because of the mass effect. And then the last thing is that the superficial temporal artery is very safe, and lately is almost always the one we use in this case of aneurysms. Thank you.
Beautiful surgery. Thank you, Kiko, very much. So now what I'd like to do is I invite my fellow David to share with the 4 panelists a case for their opinion. It's always fun. And then we'll open it up for questions from the audience and panelists asking each other questions. So David, go ahead and share your slides. While you're doing that, I'd like to show, you can read the comments. Several people loved your lectures. They found it very informative. One of you asked whether you get certificate. Yes, if you email Ingrid Menendez, she will send you a certificate of attendance in case that's helpful to you. David, go ahead.
Well, thank you, Dr. Marcos. Thank you to the panelists for their excellent presentations today, and I'm very grateful for the opportunity to share with everyone one of Dr. Marcos's cases from a few weeks ago. So this is a 71-year-old woman with a history of arthritis, and she was undergoing a workup for a hip replacement, and she described electric shock sensation in the left side of her face, intermittent for 2 weeks and self-limiting. Worked up by a neurologist and referred to Dr. Marcos for what was reported as a distal SCA aneurysm of the superior cerebellar artery. And so she had an MRI performed, which revealed this tuft of vessels in the left cerebellopontine angle. And then she was subsequently worked up with an angiogram. So I'll let this play through the post-contrast and T2 as well, focusing on the left cerebellopontine angle. Okay, and then her angiogram disclosed this vascular lesion. You can see the left internal carotid artery injection in an AP and lateral view with a CP angle vascular lesion fed by the meningohypophyseal trunk in the lateral projection, and then the vertebral artery injection, which characterizes the lesion much better. And at this point, I'll pause and ask the panelists what they think of the case, thoughts on diagnosis and management from this point before sharing our plan and our operation.
Bernard, do you want to tackle this since you are the first to speak?
Thank you, Jacques, and David, thanks for a great presentation. I missed just the first slide or two because I was distracted by a page, but I caught the latter third or two-thirds.
Trigeminal symptoms, aneurysm on CT and MRI touching the left trigeminal nerve.
I see.
On angiogram, it's more than that. It seems to be a malformation. And David, maybe you can replay.
Can we see the MRI one more time?
Oh, you want the, show him the MRI.
Yes, sir.
Maybe you can do it slowly and slow down at the, you had a nice T2 sequence, I think, also that showed it. Oh, there, right. Can you go? Yeah. Here, look at the left.
Oh, yes.
Cisterna ambiens, quadrigeminal cistern, cisterna ambiens. And then the angiogram of relevance is what happens with the carotid injection. On the lateral, you can see contribution from the inferolateral, the meningohypophyseal trunk.
Yeah.
Right there, you see it, Bernard. And
yes.
More impressively, the vertebral injection, SCA, fills this lesion, and then early venous drainage into vein of Rosenthal up the galenic system. So the question to you, and you can see, by the way, what was called the aneurysm is really a varicose venous dilatation. So number one, what do you call this? And number two, what do we do about it?
Yeah, it's very interesting. Obviously, this is a complex case. It's hard to just from these slides do a deep. But in my hands, I'd want to do super selective angiography to do a deep dive on the anatomy, but it looks like it's mostly sitting in the subarachnoid space from that MR.
It is.
And the dural supply or the meningohypophyseal supply implies some features of a dural fistula, but it also seems to have a nidus like an AVM. I couldn't tell from the MR if the that nidal tissue was sitting in parenchyma, but it looked like it was mostly subarachnoid space.
It's completely excellent points already. That's what was going through my mind, and it is in the subarachnoid space. I could not. We can go. I mean, even if we go back to the MRI, you cannot identify a parenchymal nidus.
Right.
You could call it a subarachnoid nidus. There, right there. You see.
Right.
Ali, do you differ in your thinking, or what's your opinion, Ali? Are you muted? You're muted, Ali.
I said, Dr. Morcos, I would embolize this with Tegretol, and because of her age, maybe depending on how good she is, radiosurgery or not. If it was a younger person, not 71, probably for resection, probably without embolization.
What shall we call it, Ali? Is this an AVM?
I think it's an AVM, Dr. Morcos, from that angiogram.
So why is she filling? What is she doing filling it also not only from SCA but also from meningohypophyseal trunk? So is there?
David, could you slowly play the PCA, the posterior circulation angiogram? It looked like there was a nidus there.
This is where super selective would be helpful. And the question is that it has that feel of a nidus, but is that just venous varices related to this dural fistula? I don't know.
Yeah, you see
looks
that
like
right
nidus.
there. Yeah.
That looks like a nidus, this tuft right in front of this varix. I take Bernard's point that if it's hard to go earlier, do you have like not a 3D run, but a regular frame by frame run?
Yes.
To be honest, David put this case very quickly this afternoon. There are better runs, but I thank David for quickly doing this. We thought it's an interesting case for the panel.
It is.
David, what do you have something handy? Oh yeah, you could show them this, you mean. Is this good enough, Ali?
Could you go back to the early phase?
Yeah.
Okay, next.
I can tell you this is SCA feeding it. No, there's no question about that. Then you see this venous varix that collects into Rosenthal up to Galen. But also there is unquestionably the meningohypophyseal trunk. So I guess for our audience, a general question, well, mostly to any of the panelists, is there an entity of mixed dural and PL AVM? Just summarize for our audience how you think of vascular malformations that may be in between.
It's actually a very good point. I'm sure you've seen the same, where you see at surgery dural fistulas that have a PL component or PL supply. Even like an ethmoidal fistula, I've seen cases where there's a parenchymal AVM-like component to the malformation. So I think there are mixed lesions like this, and I think again I would love to see a super selective angiogram.
Yeah, and the dural ones, Dr. Morcos Otero says, those that have been radiated before, have bled before, can sort of get these other feeders. Is there a history of bleeding in this patient?
Nothing. Very healthy. I know she's 71, but extremely healthy and active. And this thing was really bothering her, the trigeminal thing. And before I tell you what we did, but just Jorge or Kiko, any opinions on this, on what you would call it and what you would do about it? Either of you, whoever speaks first, will unmute yourself and tell us what you think.
I call it a difficult case. And I think that the key here is the how you're going to treat, going to treat, going to go after the endovascular therapy and followed by surgery, or you're going to go to microsurgery, and again, which way you're going to get there, because you have to control the dural and the AVM, because I think it's mixed malformation. This is very important. That
I think you are showing the case because of the approach you use to solve the situation. I think because for me it's an AVM. We can see the meningohypophyseal trunk involvement, but mainly is supplied, I think, from the superior cerebellar. I think for me it's very important the clinical presentation. It's a trigeminal neuralgia of the first, probably the first superior branch, and for me this is. This puts this patient in more prone to surgical treatment. In my case, the nice thing here is the approach, because you could use a Kawase approach in this case, or we could use in lesions like this one posterior infratentorial supracerebellar lateral in the sitting position. I think you can reach this lesion perfectly too. So maybe you are showing us to teach what approach you use.
Sorry.
Go ahead, Bernard.
No, I think it boils down to a question: is what is nidus and where is the nidus? And that's, I think.
But in this case, the nidus is I think you were absolutely right. It's in the cistern. It's not inside the parenchyma. And in my experience, these kind of vessels inside the cisterns are more. You can handle them. They are very resistant. These kind of vessels, and even with this small size of this malformation, nothing or very few things would happen if you go straight and by a mistake you sacrifice the vein. I think these AVMs, it might sound strange, but these are pure cisternal and are quite easy to handle. The problem here is the location of the AVM, of course.
Okay. David, what did we do?
So we did a 3/4 lateral position, supracerebellar infratentorial approach. And you can see here the petrotentorial junction above the cerebellum and this large venous varix. There were 3 large veins. One was not arterialized, though 2 were. And you can see the big venous varix headed into the petrotentorial junction there, and then basal vein of Rosenthal into vein of Galen. Dr. Morcos here is dissecting out the aneurysms associated with the vascular lesion. And it is all in the subarachnoid space, no clear intraparenchymal AVM nidus. Just a large collection of small and medium-sized arterial vessels from the superior cerebellar artery, and then the tentorial hyperemia as well, and Peel supply.
I don't know if you have some shots later, you can clearly see, so were it not for all of these little worm-like things, you can see this is a classic tentorial dural AV fistula. But I don't know if David included it, but I would put a temporary clip on one of the red veins, and the other vein and these vessels would inflate suddenly. So I was nervous about treating it just with a vein ligation, because these vessels are not within the leaflets of a dura, and I don't know if they're going to rupture with me putting a clip on the vein. You see the nice ICG. I mean, for all you know, this looks like a complete AVM, but obviously is really, at the end of the day, this is not an AVM. This is a tentorial dural AV fistula with significant parasitization from the SCA. And essentially, I did what you're seeing me do, is just coagulate those non-nidus vessels, just worm-like hypertrophied feeders from the SCA. Then I put clips across the veins entering the tentorium.
Dr. Morcos, this isn't, I mean, if it's not inside the dural leaves, I mean, that's an AVM, no? I mean, that's a cisternal AVM. Because the reason I ask is if you think this is a fistula, then in a 71-year-old, you could have gone transvenously and closed it off.
Yeah, I did not know pre-op, to be honest, fistula or AVM. It had, I mean, as we all thought, it looked like an AVM at the beginning. So I was not, yeah, you're right. If I knew, well, no, I mean, even if I knew beforehand, would you go transvenously occlude what I'm doing right now, this vein, and allowing all these congested vessels lying in the subarachnoid space kind of blow up? You know what I mean? That's what happened to them.
Sure. Then I would functionally call this an AVM then, right?
Well, but embryologically, it's not. You know, it's not. It's just. I've had several cases. Like I had one in the IAC that I encountered the same difficulty. A dural fistula with engorged feeders. You know, yeah. Go ahead,
Jack. Did you see a vein connected to the dura at all?
Oh yeah. This everything you're looking at are two red veins
coming from the dura.
Yeah, one is I call it transverse pontine vein, and one is the anterior cerebellar hemispheric vein.
You know, I saw something very similar, as I mentioned before, with ethmoidal AVM, dural fistula, I should say, and where there was a dural fistula component, there was a lot of parasitization, but you know, what we call this depends on where the nidus is, and if there's
Yeah, but you know, it's not a nidus. I mean, I really played with the lesion quite a bit, and I was able to coagulate each one of those medium-sized red things and put a clip on something that looked like an aneurysm. At the end of it, the whole thing disappeared. When I took care of all the SCA supply, I kind of developed the courage to then take the vein. You know, I didn't dare do this step till I cut down the PL supply.
And Jack, are you in reverse Trendelenburg here?
Yes, 3/4 prone, no retraction, you know, gravity.
And then reverse T, head up.
Some head up, yeah. 20 degrees, yeah. No, I mean, the approach, the view was excellent. It's
yes.
So I thought it's an interesting case to allow you guys to kind of talk about these sometimes weird mixed lesions.
Right.
Anyway,
it's a very interesting case.
Yeah, David, you have the post-op angio, or yeah, just you know, it's all gone, and she did.
Yes, here's the post-op angio.
Basically, the key here was to skeletonize the SCA and then watch the vein turn dark, right?
I think so. I cannot tell you that I wouldn't have gotten away with it by just clipping the vein, or as Ali said, embolizing the vein. But I mean, I wouldn't dare. You know, thin vessels lying in the subarachnoid space. I'm going to let them become congested. With that AVM-like nature to it, I didn't dare. So I just took them. It's gone, and there's no early venous drainage. Even if you watch, I think the meningohypophyseal trunk, of course, it's kind of stagnant now. There's nowhere to go. Anyway, okay. Well, listen.
Excellent
thank you,
case.
David. Thanks for putting it quickly together.
Thank you, Dr. Marcos, and thank you, the panelists.
Thanks, David.
Let me tackle some of the audience questions. One question by Alim Bayramov: which genetic disorders can cause vascular malformation in the central nervous system? Well, I know of Wyburn-Mason. Any of you knows of other genetic disorders with brain AVMs? I'm not familiar with any others. Okay. Question to Dr. Moura from Mohammed Asfour. He liked your beautiful presentation. Jorge, tell Mohammed, how do you deal with a swollen brain in cases of ruptured aneurysms through your mini or micro approaches?
Okay. The micro is not for rupture. It's only for unrupture. The micro is impossible because it's a borehole. It's tiny. But the mini pterional is very good for any rupture and unrupture. How I deal, if I have an hematoma, I take out the hematoma, and most of the time I use a ventriculostomy during the surgery. Give me space. I deal with the pathology, and after that I take out the drain in all the cases. You know that we follow the lamina terminalis fenestration and cisterna opening, but the field that you have in the mini pterional is very similar than the space that you have when you use pterional. You need to try it. It's the only way to follow this.
Jorge, I'm going to ask you a question that I am sure, well, I don't know, I'm speaking for them. Ali and Bernard probably will tell you. They're going to tell you endovascular is the way to go for paraclinoid aneurysms, and your skills are quickly going to become futile. What's your answer? Or I'm assuming Bernard and Ali, am I correct in assuming you might pose that question to Jorge, or you disagree with my presumption of what you're going to ask him? I'm asking you because you're both duly trained.
Ali, you want to go first? I can give some comment.
Sure. You've been in this situation recently, but you know, we looked at large series of patients with paraclinoid aneurysms, and we looked at this because I remember Dr. Day and some of my mentors talking about even in the best hands, there's visual morbidity, 10% plus. And it turns out that whatever's published in the literature supports that. So coiling versus flow diversion versus clipping, those paraclinoid aneurysms, flow diversion sort of wins. The issue with flow diversion is there's this 1% thing about this delayed hemorrhage that you can't attribute to, oh, I made a mistake and I clipped like this. So there's this unknown that causes a lot of fear. I think it really gets down to the institution and the practitioners in that institution. And if you have a surgical virtuoso like yourself or Ali Krish that live in that space of Zen and artistry, then I guess that's the right thing to do for you and your patients.
Bernard?
First of all, Dr. Moura, you gave a wonderful presentation, and I worked with Hunt for many years, and I'm very passionate about paraclinoid surgery. But I do think that flow diversion has a growing role. I think the most important point you made, in my opinion, was the idea of decompressing the optic nerve. So I think, you know, with a giant aneurysm, there is a need to have these skills, because even a flow diverter may not address that. And in fact, sometimes there's acute worsening of mass effect until the aneurysm shrinks. So I think that where it becomes hard is this: when you have a patient who has, let's say, an aneurysm that's big enough to treat, but is still unruptured and benign, let's say a 7mm hypophyseal, you could do a flow diverter in 30 minutes with very low morbidity. They go home the next morning. That's where I think that the discussion becomes harder. And flow diversion, I think, is going to play a bigger role. Where I think that surgery is still important is with mass effect. I think I agree with what you said about mass effect. So I think we need to continue to master these techniques. I think we can't ignore either at the current today. Now in 10 years, I don't know, but today we can't ignore either technique. I know that's maybe not a strong answer, Jacques, but that's my current feeling.
That's okay. That's why we're here for. We're here for our feelings and opinions. Okay, Jorge, you escaped that one. You're lucky. Okay, question from Joe Rivas. Even if you do not need to remove the clinoid, well, his question is, I guess, Jorge, again to you, is there a side, what's the visual morbidity from removing the clinoid? Bottom line of his questions, weighing the benefits of removing it versus not removing it. Tell us about what you think about visual outcome from clinoidal removal.
Yes, I think it's very interesting to put into the table as well the experience that we have with tumors, with meningiomas. Can you hear Dolan? No, it's barking.
I can, yes.
Yeah, and he wants to participate. And the thing is, the blindness that you can have with the clinoidectomy is less than 1%. Less than 1%. But I'm telling you, no drill technique. Okay, I'm sorry because I know that most of the surgeons use drill technique. Okay, and we learn a lot in the meningiomas. The meningiomas, the goal of the treatment is the preservation of the optic nerve function. I'm talking about the clinoidal and the tuberculum cell, of course. And we apply the same philosophy to the paraclinoid. It's very important because I saw a lot of surgeons who use the anterior clinoidectomy to clip the aneurysm. No. The anterior clinoidectomy in paraclinoid is to decompress the optic nerve. You don't need to think about the aneurysm. That's why it's very important that Dr. Bernard said, when the patient have no visual compromise, for example, superior epiphyseal, I completely agree when he said, but when we have a compression, the surgery must be done for the compressed optic nerve. The clipping is something that you must do. It's the same. When you have a meningioma, you need to take out the tumor. But what the patient wants is to preserve the optic nerve function. It's the same. 1% of blindness, I think, 1%. But I never seen a patient with normal optic function that is blind after the surgery. It's very rare that. No, most of the patients that you have compromised, the patient came with something. The OCT compromised with the retinal layer of the retina, of course, and the other compromise of the visual fields of something, But a normal patient that you have blindness after the surgery is very rare. It's very rare. I think that for me, we need to keep operating because when you have an optic nerve compromise, I think that the surgery is better, but a surgery that must be done in order to preserve the optic nerve function, not only the clipping.
I think there's decompression with flow diverters. That's been shown. It may take longer and may not be as effective in the acute time period. There's certainly decrease of mass effect, whether it's in the basilar, whether it's in the paraclinoid area, even with coiling, if you will. Brock Chen showed that mass effect goes away 50% of the time in the same windows. So this concept that the aneurysm is still there, I don't know. I don't think that's true. But to your point, surgical decompression is faster, but mobilizing the optic nerve.
Okay, Bernard, a question for you from Nikolai Melita. It's a kind of a general question, but to what extent do you believe Aruba has influenced the neurosurgical practice, even with its design flaws?
Well, we know that I could give you the hour answer. Or
That's right.
I'll give you the 1 minute. So anytime there's a randomized study, actually, this would be a good study. The impact of randomized studies on clinical practice and referrals, the bypass study.
It's been done, actually. There
Yeah.
are several, yeah.
Yeah.
Right.
And so the bypass study, bypass referrals drop. Look at, embolectomy for stroke, positive studies, immediate growth of clinical practice. So randomized studies have impact, and sometimes negative, sometimes positive. For example, the epilepsy trials were positive, but it didn't impact the clinical practice because of other competing interests. But so this is, so the impact is clear, but here's what I would say about what we should do. I think neurosurgeons need to be more involved in clinical trials, so that if there's an AVM study, we need to have our residents get degrees in clinical trial design, lead clinical trials, at least sit on a team that runs clinical trials. Because if we abdicate that to other specialties without our presence, the trials are not going to be as well done. Because when you're designing a clinical trial, if I knew nothing about AVMs, I should have on that trial somebody like Jacques Marcos, who lives and breathes in an ICU taking care of these patients. You cannot have a trial done without that perspective. And so I think we need to have a seat at the table is my bottom line answer.
Okay. Kiko, I first of all, I'd like to thank you for being awake well after midnight Spanish time, but that's what Spaniards do. They stay up late. I know. You probably are starting dinner right now, aren't you?
Just waking up.
1 a.m.
You're right.
Kiko, I'll ask you a question. As beautiful work, as I know you know, the larger the MCA aneurysm is, the lower the flow is in the MCA. So, and I know you use the Charbel probe like that. And haven't you found that the need for a large conduit is very rare for large giant MCA? Usually, the flow is so low. Even a tiny STA is enough.
I learned that from my experience, and also for Fadi Charbel's lectures and papers. I told you in the presentation that we seldom use anything but STA from MCA, especially in these beasts. That Fadi Charbel used to say that they are flow creatures.
Right.
But it's like many other, when hunters go to hunt animals, they are almost dead, but not. Sometimes they are more dangerous because of ischemic events and thrombus and embolus.
Right.
So of course you're absolutely right.
And one of the questions you said about distal occlusion and how often it works. I have a dramatic failure of a very giant M1 aneurysm that I occluded distally, but it was so large, it wasn't enough to occlude distally and do a bypass. There was this eddy current that kept on going inside it. Yeah. So I think distal occlusion works. I don't know how to define it hemodynamically, but it perhaps cannot be extremely large, and perhaps it shouldn't be kind of too spherical. I think my impression is the more sausage shape it is, the more likely it is to work, because I do have that spectacular failure case.
But probably because there was an early branch, a large artery, quite large artery, coming off the aneurysm, maybe.
Yeah. Well, guys, it is 7:21, and I don't want to keep you much longer. Does any of you have a question, some comment to the other debaters, anything? If not,
I'll just end with a comment. I just want to, again, as I open, thank Jacques for continuing to organize these sessions. And really, it's been a privilege to be with Dr. Mora, Francisco, and David, and Ali. Thank you, everyone.
Guys, thank you so much. Thank you for the audience. And I see you next month for a skull-based feast. Bye, guys. Thank you for your time.
Thank you. Thank you.
Good night, Kiko.
Good night. Thank you very much, Jax.